Welcome to Interdisciplinary Case Miles, a podcast where real runner stories meet clinical expertise. We discuss real cases that are anything from weekend warriors all the way to elite athletes, while using our evidence-informed approach.
I'm Dr. Sara Raiser, a running medicine physician focusing on helping runners prevent and recover from running-related injuries while optimizing health and performance.
I'm Kelsey Pontius, a sports dietitian helping runners to fuel smarter, recover better, and help avoid the risk of injury so that they can meet their goals.
And I'm Dr. Mihevc Edwards. I'm a physical therapist and orthopedic specialist, and I've been treating for runners for over 15 years. And what I do is help them get back stronger and better. We are going to jump right in today in our episode for our first case. And this time, Kelsey is going to present it because this patient actually presented to her. So Kelsey, I'm just going to have you start right off.
Yeah, so this patient first came to me after being a referral from his sports medicine physician, and noticed I said him. This is a male athlete and he's a runner. His physician referred him to me because he was in an injury cycle with, at that time, included, I think, multiple stress fractures of his lower extremity. So I think it was tibia, fibula. I don't know exactly, but I do know that part of his leg. A lot of tendinopathies in that area too. And then the thing that kind of gave that physician, maybe put him on the tipping point, was his lab. So he had low testosterone levels and low ferritin. And so he came to me and I started with assessing his diet, which is always my first step, and assessing his nutrition needs. At that point, he was out for injury, but he was doing a great deal of cross training. Something else with this culture of athletes, they love data. They follow professional athletes, especially out here in Boulder, Colorado. They're following what professional athletes are doing, how they're training, the data points of everything. And he was definitely trying to emulate the training methods of a professional triathlete as he was cross training minus running. And so I assessed his diet. He was negative he didn't trigger for any eating disorder risk on my side. His job included that he had long days where he was on back-to-back meetings, oftentimes traveling within the city a lot, so in the car a lot during the day. So I realized that he was going long periods without food, which in my world, we call that he had within day deficits during the day. And then also what I think is really important about him is that he was a college lacrosse player. And this was just something he mentioned in passing, but he maybe didn't gain the college experience that he was hoping for. And so then he had success in marathon running. And so he was really trying to get all of the value out of his body, all of the quality out of his body. And he had a really great first time marathon. And so he was trying to really capitalize on his training at the time. And then also with more appointments, as I built more rapport, I learned that during that time he was going through a breakup. And before he was diagnosed with stress injuries, he was spending a lot of his weekends skiing, which again, tons of time on the mountain, not enough snacks, going long periods of time without food. Also, imagine a long run and then leaving to go to the mountain to ski, very high nutrition needs and at altitude. So that's, kind of concludes my assessment of him. Once we started fixing the low energy availability and correcting his within day deficits, we did that by adding nutrition into the earlier part of the day around his training. And the formula that I follow to kind of make these corrections is 50 calories per kilogram of lean body mass. And he has had DEXA scans before, so I had access to that information. And then I added on his cross training, which was a lot of cross training. It was an additional 1,500 to 2,000 calories on top of the 50 calories per kilogram of lean body mass. So that part can be quite variable. And then, his ferritin quickly improved, his testosterone levels quickly, but he wasn't even 30 yet. He was in his late 20s. So his testosterone became more appropriate for age. once he healed from those bone stress injuries, he had a long period of time where he didn't deal with as many niggles or reoccurring injuries that kind of came up. Fast forward, he got into the Boston Marathon and we were working on his pre-run nutrition, and he started explaining symptoms that sounded like reactive hypoglycemia, which sometimes can happen in REDS cases. And I worked with him on trying to incorporate pre-run nutrition, but with that intervention, sometimes the only way out is through, and you have to trial and error, and then sometimes it gets worse before it gets better. And he just, with the time frame he was on, he said that he felt worse adding any kind of nutrition. So he chose to do his training runs fasted, which was against the advice I was giving him. And later into the summer, we found that he had a grade 4 stress fracture to the femoral neck. So that is kind of, and then we kind of went back to now he wasn't cross training as much, and we went back to restoration calories and bone healing in terms of calcium, dietary sources, and supplemental sources of vitamin D, vitamin K, magnesium that helps the vitamin D absorb, all of those things. So, yeah, I think the biggest thing that I wanted to talk about is with REDS recovery, there's multiple organ systems affected, and it really can take a long period of time to satisfy all of those systems.
Thank you for that, Kelsey. So a couple things I wanted to pull out for you to give the audience a little bit more information before we jump to Sara. Will you explain what reactive hypoglycemia is? Because not
Yes.
everybody knows what that is.
Yes. So reactive hypoglycemia, without like doing a quick like search of the exact definition, the way that I would define it is essentially blood sugar that, as it can happen in the morning for people that might have type 1 or type 2 diabetes, where your blood sugar essentially spikes in the morning because like cortisol is spiking as you wake up in the morning. And so it spikes and then it drops really quickly. And then it also can happen in response to having a meal or even just a carbohydrate source, and blood sugar spikes and then drops really quickly. And then the symptoms that kind of follow that is the lightheadedness, the dizziness, sometimes a headache. And so sometimes in REDS, we see reactive hypoglycemia because our bodies are suppressed of hormones that help regulate blood sugar, such as insulin, glucagon. There's probably others involved too. And so that can be symptomatic of REDS.
Okay, so would it be fair to say, and correct me if I'm wrong for both of you, that if somebody has been in REDS or perhaps has been training in a fasted state, that when you start to reintroduce some of the foods that they need for training, such as carbohydrates, they could have some of these symptoms and make it difficult to add things to their diet during their training cycle?
I think that's really fair to say.
Okay. I just want to make sure for our audience so that because whenever we change diets or whenever people try to add new things and then there's not success, they quickly stop them. So this is something that you have to work through, correct?
Trial and error, pairing of foods, types of carbohydrates, that kind of thing can really help to kind of minimize those symptoms and time.
Great. Thank you, Kelsey. Okay, so now I want to jump to Sara because Dr. Reiser, I would love to hear your thoughts on this case from your perspective, what you would want to look at and how you might want to proceed with a patient like this.
Well, it would be awesome if everyone came packaged like Kelsey just did, and I already knew all this information. But of course, femoral neck bone stress injuries, just to give you a little medical background on them, they are one of the scarier ones, right? So we can have a bone stress injury on either side of the femoral neck. The superolateral aspect is what we call the tension side. So if you get a stress fracture through that side, it's much more likely that it could complete and it could end up needing surgery. And often, yes, Kate.
Sorry, just use words that people that aren't in the medical world might understand. Like where on the bone is that? Is on the outside, the inside? Where is that?
Yeah, so superolateral is kind of upper outer aspect. If you've got an upper outer and a lower inner aspect of your femoral neck, the upper outer is going to be more likely to complete and not want to heal as well. And honestly, if I've got anyone who has any level of fracture through that side, they're usually going to the surgeon to get hardware to make sure that thing doesn't complete. On the other side, we're more likely to be able to treat it conservatively. Usually it's 6 weeks of non-weight bearing, which is like one of the worst things to tell your marathoner who's getting ready to run their marathon in a couple of weeks. And I've had a couple this week, unfortunately. We've got a marathon coming up locally, and unfortunately, several injuries are coming up. And it's one that we just we don't give them a chance to potentially have a disastrous injury. If they have a fracture and it displaces, it can mean death of some of the bone cells, and it could potentially go on to be a hip replacement. And so I like folks to know that this could potentially be catastrophic, and we just don't want to mess around with it. So these are folks that if I have a suspicion, I'm putting them on crutches, non-weight bearing to walk out of the office that day before we've even gotten an MRI to confirm what's going on, because it potentially could complete just with walking. So these are scary injuries. And with that in mind as well, we think about nutrition as one of the top things here. So nutrition and recovery, because this is what's considered a trabecular rich bone, which means that it's a softer type of bone. And it's also a very large bone in your body. So if you've done enough work to potentially cause an injury in a femur, it's quite significant. So we've got a lot that we need to do to be able to address why this happened and make sure it doesn't happen again, and also protect the bone and make sure this thing heals. This is one of the injuries that I absolutely am getting an MRI for. I order it stat. I want it in 1 or 2 days. I make them non-weight bearing, and I'm typically also repeating imaging in 2 months before I get them back to activity, because generally these are also folks who are doing really high volume activity. This is the marathoner and ultra marathoner, and so I want to make sure they're safe. So those are the big things from the femoral neck standpoint. And so when I hear bone stress injury, we talk about medial tibia, so the inner aspect of the tibia versus this injury. We're talking about a lot of different things. They're both bone stress injuries, but we're leaning much more heavily towards the nutrition aspect, and certainly scarier with bigger consequences if this thing continues and doesn't heal. So those are the first things I'm thinking about. So the patient I saw today, that's all we did. We didn't broach other concepts. We just need to figure out, is this what's going on? And then we need to figure out what direction we're going from there. And of course, I would send this person to a dietitian. I would get lab work. I think the lab work is really important. And Kelsey mentioned a number of important points here, including the ferritin. So low ferritin can certainly be related to low energy availability. Low testosterone certainly can. And low testosterone can also make you feel really crummy, in addition to the fact that it's associated with low energy availability. So there's a number of lab markers that are really important from this standpoint. A lot of them may come back and look normal, but if they're in that low normal, like the lower quartile, and you see a bunch of these numbers like your free T3, which is one of your thyroid hormones, your ferritin, your testosterone, for cortisol is elevated. So we kind of put all these different pieces together to figure out what's happening. And clearly, when there's a femoral neck bone stress injury, there's something going on from the nutrition aspect, whether it's low energy availability or a medical condition that's happening too. And I also think that a couple of things you both brought up, in terms of the transition with nutrition. Like one of the patients I asked today, I'm like, how are the changes going? Like, you're adding all this nutrition to your day. Like, do you feel good? What kind of changes are you noticing? Are you fatigued? Are you sleeping? Are you having those symptoms of like bonking? So I like call it bonking in the middle of the day. You're not even running, but you kind of hit the wall. Like, what happened? And those can certainly be complaints. And I think if you set them up, like you were saying, Kate, if you set them up for those expectations of what to expect, like, hey, we're going to get through this. We can do some troubleshooting, but we're going to have to get through this piece of it to get to the other side and feel better is important. So certainly would get this person in with physical therapy and biomechanical evaluations when the time is appropriate, when they're safe to do activity. And these folks are not doing cross training with a femoral neck stress injury. I'm getting them through that healing phase, and then we start progressing. So we bring them back quite a lot in terms of their deconditioning that happens, unfortunately, to keep their hips safe and make sure that they go on to have a healthy hip and get them back to marathoning.
I think one of the important things, sorry, Kate, if you don't mind me mentioning the MRI thing that we talked about before we hit record. Also, this athlete that Kate thought was worth mentioning got one of the self-paid MRIs before he was able to see his physician. And unfortunately, the report from that came back as inconclusive. And then he brought the disc to his physician that was like, well, actually, you have a grade 4 stress fracture. And his symptoms were just getting worse because he was continuing to run on it.
Yeah, I think that's a really important, excuse me, a really important point because a lot of our athletes now are going to these MRI places where they can just get an MRI and we don't know who's reading them. And it is really great to have a physician that you trust that can read the MRI because it can be vastly different depending on who's reading it. And especially with something like that, it's really, really important to get the right information. And something that I learned from working with Sara and other physicians is that it's important to get not just one MRI in the beginning or one image in the beginning, but with an injury like this, you want to make sure you're getting imaging, like you said, before you start something like with me, like a return to run program. So from a physical therapy standpoint, once I'm waiting for someone to be cleared before I'm going to work with them. So I want a physician to say, you are good to go from a running standpoint. And once that happens, then there are a lot of different things that I have to look at and take into consideration. First thing is, why did this happen in the beginning? So yes, obviously there is a nutrition component, but because Kelsey started with this athlete, I know that that's managed, which is lovely. But it's also going to be other things. It's going to be training load. So it's not just nutrition. It's going to probably have some kind of biomechanical piece to it. It's probably going to have some kind of strength component to it and some kind of training error. So we need to start going back in the 3 months before they got injured and look at what their training looks like and see if there was a major spike in a run. We need to see how much overall running they've done. What are the other things they're doing on their feet? Like you mentioned, he's skiing, he's active. But if this was somebody that was maybe a nurse versus somebody who was sitting at their desk, they would have more time on their feet. So I'm looking at load from that perspective, in addition to mental and emotional load, which a lot of people, kind of push off the side because all three of those things are really important when I'm getting someone back to their return to run. And so I'm going to do a return to run screen, which is about 10 different tests that I take them through, all the way from like single leg balance to hopping. And particularly with the femur, we want to make sure they don't have any unloading pain. We want to make sure that they can hop appropriately. We want to make sure that they can do resisted adduction. So that's like bringing your leg in. So a Copenhagen plank is a good example of that, testing that out. So you want to make sure that they can do all that. If they can do all that, we're going to build their strength back. We're going to be working on dynamic control, plyometrics before we're actually running. So when they get the clear, they're going to want to run immediately. But unfortunately, I'm not going to let them. I'm going to get them walking. I'm going to get them cross training, and I'm going to get them to load and strengthen and do plyometrics. Then I will begin a return to run program after they've passed all my tests. That is a walk-run progression. The other thing that I'll say about that is the way that I build out those return to run programs is dependent upon their history. Someone with REDS or history of REDS or eating disorders is going to get a very different program than someone that doesn't have any history like that. Someone who might have been, this is a male we're talking about, but if it was a female and they were breastfeeding, this would be a very different return to run program than if they weren't. So all of those things are put into consideration. And the way that I progress it is always going to be slower than that athlete wants. So it's really, really important to set expectations and also have them go through it with you and give them goals each week. So say, okay, this week, if you complete this, then we're going to increase by this much, and explain why throughout the entire program. And Kelsey and I have a patient right now that's really pushing me hard, like wants to go faster, wants to add more mileage to their return to run program. And I absolutely cannot do it because of their history and because of their injury. And so just being really, you just have to be so tough, and it's really hard, guys. From a PT perspective, I just want my athletes to know, like, I don't want to hold you back, but we have to do it if we want, especially with an injury like this.
Well, and I always like to tell people too, you have like the peak like where you want to train the highest possible point, and then right above it, you have your injury threshold. And you never want to pop over that injury threshold. So we'd rather stay on the air on the side of being a little undertrained than risking an injury again.
Well, and with a femoral neck fracture or stress injury, whatever you want to call it, whatever level it is, it's going to be very different than coming back from a tibia. That's just the bottom line. It's just very different. You have to take into consideration all these different things. And that's also why you can't build your return to run program by yourself, or you shouldn't use, an online source necessarily for that. You should have somebody who's taking into consideration all the factors and looking at each stage of the progress and be willing to take you back. There should never be pain. If there's a lot of tightness, that's a red flag. There's just so many different things that you have to look out for.
And I want to put in a little plug for the interdisciplinary approach to these cases, because I think Kate pointed out a couple of really important things. For example, understanding that her patient with a femoral neck bone stress injury should have a repeat MRI to make sure we're going in the right path. She can ask the right questions to figure out, what the physician that's treating the patient is doing, and even understanding that REDS means we need to consider taking things slower, and this can't be the standard return. And those are not necessarily things that every physical therapist is considering. And so I think the crosstalk is just so important. I need to understand what physical therapists are doing and vice versa, and that's how we can give the best care.
Yeah, absolutely.
Quick soapbox.
No, I love it. I love it so much. That's the whole reason we're doing this podcast, Sara, is to explain how we work together. And it's true, like without the nutrition component, without the component from you, I can't do my job, and vice versa. Because when it comes down to it, we need to know what the bone looks like, and we need to know that they're fueling appropriately so it doesn't happen again. And we need to have load management. And those are the three pieces of the puzzle that we're bringing together when it comes to this case.
Yeah, and I think one thing that can be really common, one common thread between a lot of these types of cases is something going on in one's life that grief, a big stressor, your moving states, or, and oftentimes we forget about those things, but the body is stressed out in those scenarios, and we've got to take that into consideration when it comes to the training and all the other loads. Stress is stress, as Kate would say. But sometimes we forget about it, and it's not the first question that we ask, because instead we're looking at the MRI images, So I think it's important that we remember our patients are human and whole, and we've got to remember what motivates them to do what they're doing. I did want to ask real quick, Kelsey, could you talk more on the within day deficits? Because I think it's so important, and can you kind of identify why that's something you discuss so often?
Yeah, I would say in practice, this is one of the first most severe cases that I've seen it impact a male athlete, which tells me as a provider, a lot of the research being done and how, and I'll come back to within day deficit, is on female athletes, because I do think that there's an element where female athletes may or may not be more sensitive to this. But in this case specifically, this individual case we're talking about, this athlete would eat a ton of calories at the end of the day. And so he felt like that was enough to catch up prior to meeting with me. But he was symptomatic of REDS, right? So within day deficit, essentially that is going a long period without nutrition. And it's magnified when there's a higher demand, such as exercise or training, and a long period of time around the exercise without nutrition magnifies it worse. So we're put into a pocket, as I like to call it, of low energy availability. And there is lower blood sugar in that. There's elevated cortisol, and that just puts the body more at risk for injury and other RED symptoms too.
Right. So one of the important things I think you're saying is it's quite possible they're getting enough calories in a day or energy
Yes.
in a day, but they may not be getting it so that their body can actually absorb it and use it, and it's not necessarily there when they need it.
Yes, we want the nutrition to align with the demands of the day. And that's why eating around our training, before, possibly during, after, and so forth is so critical for reducing the risk of injury, helping your recovery, staying out of RED, so forth.
I want to bring something up that kind of links that and something I meant to say earlier. And we're talking about how this athlete was doing a lot of cross training. And so when it comes to cross training, that's still training load and that's still training stress on your body. And if you're doing a lot of cross training from like a muscular standpoint, and we're muscles protect bones. If your muscles fatigue and they're fatigued for any reason over and over and over again, they can't help the bones support the weight that you're putting through them. And so not only are they have this big calorie output, but they're also fatiguing all the things that are helping their bones stay healthy when they are actually running. So there is that component of it. And I do think that a lot of times we think of cross training as super safe, and it usually is. But if it's used in a way that with a regular athlete, that the elites use it because they're different, they're a different situation, then it can become detrimental because they might not be able to support their body. The other thing I wanted to say is that from a biomechanical standpoint, things that I would be wondering about is in their gait would be like, how is their rotational control? Because if you think about the femur and how the foot lands, if they are they're pronating a lot, if their knee's into valgus, if their their femur is turning in, we call it femoral internal rotation, then they're also causing a lot more stress on that femur when they're landing. So those are things I'll be looking at when I'm looking at functional assessment and gait analysis later on, is because how are they controlling their body as their foot hits the ground? The other thing I'll want to know is about their arm swing. Is there relative rotation? Is their hip dropping? What's happening? How are they absorbing force, and how are they releasing that force when they run? Because our body is like a rubber band. It stores it and it releases it. And we also have to go through that whole range of motion from hip flexion, which is like triple flexion, where your foot is bent, your knee is bent, and your hip is bent, all the way to triple extension, where your foot is out, your knee is out, and your hip is out. And so all of those things are going to be things that I'm also thinking about and looking at when it comes to this athlete.
And then from my perspective, looking at the hip joint. So I think we talked about hip impingement a little bit in a prior case, but looking at the shape of the hip, which can potentially predispose folks to have a femoral neck bone stress injury. Not usually the only thing, but there's got to be a reason why one area is weaker and you get a bone stress injury in that particular spot. So if the perfect storm hits there, you always look for other anatomical things as well. And so like the case I had today, the conversation was, well, there could be a little bit of hip dysplasia, so an abnormal shape of a hip, which puts them at higher risk for a labral tear. And then if they have poor mechanics and poor rotational control, then they're at higher risk for injuries there too. So certainly the anatomical piece is important as well.
Great. Well, thank you very much, guys. I'd like to kind of close the loop here, and we'll do what we normally do, which is each of us will talk about, 2 or 3 things that we really want people to get from this case from each of our perspectives. So we'll start with Kelsey. Kelsey, what are 2 or 3 things that you would like people to take home from this case from a nutritional standpoint?
I think exactly what Dr. Reiser asked me about is considering not only the overall nutrition across the time frame of a day, where a lot of times people can even be in a little bit of a restrict binge cycle too, where they're not getting enough calories and then they're consuming a lot at the end of their day, and then they're waking up the next morning like, oh, well, I had that big dinner and then more ice cream at the end. So I don't need it before I train. I see that trend a lot. So I would say making sure that your timing of nutrition around your training and making sure you're aligning your nutrition with the demands that you have is critical.
Great. And then what about you, Sarah?
Yeah, so one thing that I tell my trainees is if you see a runner with groin pain, it is a femoral neck stress fracture until otherwise proven. And that keeps you out of trouble because then you check and you make sure. Now, sometimes it's hip arthritis or it's a labral tear, it's something else, but you don't want to miss that femoral neck stress fracture. So anytime I have they're like, I just have a little bit of groin pain. I'm like, what, groin pain? So always have our spidey senses up for that. The other thing that I didn't bring up earlier, but I think is really important, especially for the layperson who talks about a hip flexor strain or tendinitis, relatively uncommon, and usually there's something going on underneath that. So I want to remind folks that muscle pain can oftentimes be guarding, that's reacting to angry bone, so an injured bone, or trying to protect it. So oftentimes in runners, it's not necessarily the muscle that's the main issue. That's usually a secondary issue, and you want to make sure you're not missing that bone stress injury underneath it.
think you stole mine, Sarah, but that's cool. I'm just kidding. So one of the things that I would say is that if you're treating an athlete and the symptoms keep coming back and you've treated them, 2 or 3 times and it's still a lot of tightness, especially hip flexor, like you mentioned, or even glute pain, or maybe pinching, where they think that it's like TFL or something like that, definitely refer out if you're a physical therapist and make sure that they're getting imaging because it may be a femoral neck stress fracture. The other piece I would say is hold tight, PTs, or whoever's doing the return to run program. Like, you just have to be strong. You have to stick to what you know and take it slow. If they need it slow, you can speed them up if they can tolerate it. But there is no one return to run program, but there are definitely milestones that you can pick along the way. You have a good return to run outline that they have to meet and they have to pass before you bring them to the next stage, and make it run walk, and make sure they're doing plyometrics before you start. So that would be kind of the top things that I think. So thank you very much, girls. I'm so glad to be here with you. This is my favorite time, is to get to spend time with you guys and nerd out. So I'm glad to be with you guys, and I'm so glad that you listeners are listening to us. So if you like this podcast, we would love for you to share it with a friend. If you know someone who's gone through this or any of this information could be useful, please pass it along. That's how we're going to grow this podcast and bring really good scientific information to people who need it. If you're a healthcare provider and you like this podcast, share it with other friends, because that's, again, how we're going to grow. So I don't know, like this, follow us, all the things, right? And if you guys have a case that you want us to go through, email us. It's runcasemiles@gmail.com. So until next time, happy running, and we will talk soon. Thank you very much.